Hello.
Hello. Okay.
Hello.
Yes.
Okay. Are
Yes.
we ready?
Yes, sir.
Okay. Uh, Good morning. In London, and I'm in Thailand. So good afternoon. And my name is Associate Professor Dr. Paniti Netinant. I'm the session chair for the 3C sessions. So uh, we will have the presentations about 8 or 9 paper. So uh, welcome all of you for being here in this sessions. So if you are ready, I'm not sure, Dr. Nishle Modi, are you online? Okay, that would be okay. So, I think it's time. So we will begin for the first presentation. The first presentation is going to be a review on schedule temporal data mining in application of traffic forecasting and climate change analysis, a narrative review. The presenter is Sir Calvin. Are you ready?
Yes, sir, I'm ready with it. Should I share the
Okay.
screen?
Okay. If you are ready, you may begin your presentation. Thank you.
Yeah, you can
Uh,
start your presentation, Professor.
okay, sir. So is the presentation visible?
Yes, it is.
Good morning, the respected chair, distinguished panel members, and fellow researchers. My name is Srushti Sudhir Sawan from Datta Mega Institute of Higher Education and Research. It is truly honored to present our review paper at ICICT London 2026. Today, I'll be discussing spatio-temporal data mining, commonly referred to as STDM, and its growing role into critical real-world domains, traffic forecasting, and climate change analysis. Although these domains appear different, they share striking similarities. Likewise, in data structure, the challenges of the models, and also between the computational demands. Okay. Here we'll start with spatio-temporal data mining. That why is it important? And uh, according to it, here are the model systems. I have tried explaining it in a diagrammatical manner. The modern systems, whether urban or traffic networks or global climate system, it generated data that is not only in large in volume, but they are also dynamic across both the space and time. So traditional data mining techniques fail to capture these evolving patterns. Here, the STDM help us to understand that the events which are occurring, how they are occurring and when they are occurring and where actually they are occurring and the patterns they are evolving over time, which is making it indispensable for real-time decision making, long-term forecasting and policy planning. Now, as we started with STDM, what actually is STDM? So STDM here refers as a technique that extract the meaningful patterns from data having the spatial coordinates and temporal dependencies. Like in a simple term, like how does a traffic congestion propagate across a city over time is the answer for this. So STDM combines the machine learning, deep learning, graph modeling, and also the analysis, like in a statistical manner. It helps us to understand or to handle the complex dependencies that will change both geographically and uh, temporally. Uh, Next, we'll go to the data ecosystem. Now, here, the data ecosystem I have been divided into two ways, that is the traffic and the climate. These both systems are the most important one and they are rich but complex data ecosystems. In traffic system, the data sources include GPA trajectories, roadside sensors, the traffic cameras, and the weather APIs. For the climate system, we usually rely on satellite imagery, weather station, reanalysis data sets, and also the environmental sensors. Despite the domain difference, both involve high dimensional data, real time or long term streams, and multi source heterogeneity, making it unified modeling extremely challenging. These are the most, you know, the unified challenge between these two. Now, the traffic forecasting evolution, I have made it in a graph manner. The evolution of traffic forecasting models. Early approaches were statistical, focusing on linear trends, but this has shifted towards the machine learning models. And more recently, it is turned into a deep learning architectures. Now, the GNN, that is the graph-based neural networks, have become dominant because they are naturally the model road networks as graphs, capturing spatial dependencies between intersections while maintaining the real-time prediction capabilities. These models significantly improve congestion prediction and route optimization in smart cities. Now, the climate change modeling. Climate change modeling, here the focus is on long-term dependencies as the traffic modeling is usually forecasting is usually a short-term dependencies, but here in climate modeling, it is a long-term dependencies, non-linear interactions, and physical consistency. Models such as CNN LSTM architectures are effective for extracting the spatial patterns and temporal trends from climate data. More recently, the transformers-based models and the physics-informed neural networks have gained attention for their ability to capture long-range dependencies while respecting the laws which we have also been through in the physics. So it is completely based on the laws of the physics. Here I have made a slide regarding the comparative summary between both the traffic and the climate. So here, as we compare both domains, we observe a clear contrast that the traffic model prioritizes the real-time accuracy and fine-grained spatial modeling, whereas the climate model emphasizes a long-term stability, interpretability, and physical realism. However, both domains have increasingly benefit from hybrid deep learning architectures that combine a spatial and temporal reasoning. These are few shared challenges. Despite the domain differences, several challenges are also shared at the same time. I have mentioned it with the bullet points that these include the data heterogeneity, missing or sparse objectives, high computational cost, and lack of interpretability in a deep learning models. With additionally, I have added it as scalability and privacy concern remain the critical, especially for the real-time traffic system and sensitive climate datasets. Okay. Now, these are the emerging directions. Looking forward, several promising future of STDM. There is growing interest in interpretable AI, transferring learning across the regions, and federated learning to preserve data privacy. Physics-informed deep learning is particularly promising for climate science, while energy-efficient AI systems are essential for sustainable deployment. Um, Contributions of this review. The review I have made have main three key contributions. First, it is provide a unified comparison of traffic and climate STDN. Second, it defines the shared technical gaps that hinder real world deployment. And the main, which I found it more accurate, is cross domain methodological insight. This is going to help in inspiring the future hybrid solutions at the same time. I'll conclude my topic with these, like deep learning dominates the modern spatio-temporal data mining. The graph-based models are powerful for spatial reasoning in traffic systems, While climate models demand physical consistency and interpretability, future research must focus on explainable, scalable, and responsible AI systems that bridge both the domains effectively. Thank you for your time and attention. I look forward to your questions. Thank you.
Thank you for the presentation, madam. Sir, do you have any question?
No, I don't have any question. Thank you.
Actually, I do have just comments because when you compare about the GNN and about the LSTM, actually it is a different domain, but you haven't mentioned about how to use it because the GNN is for a specific, normally it's for a wide area. And for the LSTM, it should be a focus point. So actually, it is a good topic, but you should mention the difference of data to be used for LSTM versus the GNN. Thank you.
Thank you, sir.
Next, we have Sharath Halumani presenting Development and Validation of Evaluation Form and Inclusive Development Support Module Empowering Mothers and Healthcare Providers in Preterm Infants. Moving on. For the third paper, we have Efficacy of Thoracic Squeeze Techniques and Naxon Technique in Improving the Functional Outcome in Neonates with Preterm and Feasibility and Preliminary Study by Ashik Ghosh and Sharad Hulumani along with Shrutika Sharad. Ashik Ghosh.
Yeah. Good afternoon. Am I audible? Hello.
Yes, loud and clear.
Thank you. Thank you for the feedback. Okay. So, thank you for giving me the opportunity. Respected all the chairs, respected chairperson, respected other dignitaries who are sitting over here. I'm going to start my presentation. So, here it is.
Excuse me. Can you share your presentation?
Yes, sir.
Sure. You just lost your presentation.
Just 1 minute, sir. 1 minute, 1 minute.
Okay.
Is it visible? Hello.
Yes. Okay.
Yeah, thank you. Yeah, obviously. So my topic is efficacy of thoracic squeeze technique and Yaxon technique in improving the functional outcome in neonates with preterm, that is feasibility and preliminary study. My ID is 482. So we all know that preterm infant is one of the most sensitive population all over the world, and all the doctors and other healthcare workers are just struggling and also working very hard, and also they're just making various types of new techniques and innovations in order to improve the condition of the preterm. So, preterm births occur before 37 completed weeks, categorized as moderate, that is 32 to 36 weeks, which is very preterm, that is 28 to 32 weeks, and extremely preterm, that is under 28 weeks. So globally, we all know that preterm infant, there is a high chances of mortality, and if mortality persist, then there is a chances of morbidity. So there are various types of disorders and various types of deformities they actually suffer. For example, foremost is neonatal respiratory distress syndrome, which is very much common, and from there it can lead to bronchopulmonary dysplasia, for which it is being staged by Sarnath and Sarnath staging. And also then there are other kind of deformities like poor such-swallow coordination, brain hemorrhages, then long-term issues like developmental delays, cerebral palsies, then infections, jaundice, and temperature instability, which is very frequent. And now there is a specific physiotherapeutic treatment which is being like applied after giving a thorough review. And one of the foremost is thoracic squeeze technique and positioning, which helps in lung expansion as well as motor development, aligning with neonatal rehabilitation processes. And then kangaroo mother, which also promotes bonding and stability. Another is South Korean technique, that is conventional touch, which is also known as Yaksan technique, which helps to improve the overall compliance by reducing the pain which is being suffered by the preterm infants. So this is the research question which is being made in the PICO format, that is in preterm neonates with respiratory distress in NICU, that is the population. Does the thoracic squeeze technique compared to Yaksan technique improve respiratory parameters, behavioral organization, and physiological stability immediately post intervention and that at 4 weeks? So I am moving forward with this. Now, this is the aim and objective. This study aims to evaluate and compare the effectiveness of the thoracic squeeze technique and the Yaksan technique in improving respiratory function, physiological stability, and comfort in preterm neonates with respiratory distress admitted to the neonatal intensive care unit. The objectives of the study is to examine the effects of thoracic squeeze technique on respiratory parameters, including respiratory rate, oxygen saturation, clinical signs of respiratory distress, and other neurodevelopmental disorder in preterm neonates, which is being described well in the outcome. So this is the methodology. You can clearly see the intervention is being going on in a NICU setting. The whole study is being conducted in the NICU of a tertiary care hospital, and all the CTRI ethics committee has been approved. Here the preterm neonates with respiratory distress and other neurodevelopmental disorder will be enrolled following the parental consent and allocated into groups to receive either the thoracic squeeze technique or the Yaksan technique along with the standard care. Respiratory and physiological parameters will be assessed before and after intervention to evaluate the feasibility, safety, and preliminary effectiveness. So the most important is the outcome measures, and obviously after the treatment, therapeutic treatment, there will be a good compliance, which is one most foremost is Ballard scale score, which is also known as Ballard maturational assessment. We are well aware about that. This is the foremost common scale which is being used in the NICU scale, setting to check the progress of the neonates. And this scale estimates gestational age in newborns by evaluating both physical and neurological maturity. And it has been developed by Dr. Jean L. Ballard in 1979, which includes physical and neurological criteria. Each criteria is scored in 5. The original Ballard score runs up to 50, while the new Ballard score is down to -10 for extremely infants. Then Anderson Behavioral State Scale, ABSS, this behavioral assessment tool actually developed for preterm infants to track developmental and behavioral patterns. It is also very much important in order to check any kind of deformity and any kind of neuromuscular developmental disorder. It categorizes behavior into standard quiet sleep, active sleep, then inactivity, active alert, then moderately alert, okay, then detailed observation of the state and behavioral organization, and then peripheral oxygen saturation, which indicates the percentage of oxygen carrying hemoglobin in the blood compared to the total hemoglobin, provides real-time insights about the efficiency of oxygen transport, respiratory stability in neonates. So here the participant will complete at an assessment at week 0 and 4. The primary endpoint is immediately post-intervention, that is week 4. Physical activity, balance, and psychosocial well-being, which has been assessed, will be between week 0 to week 4. Now here I am into the results. That is 25 preterm neonates underwent eligibility screening. 20 individuals were randomly divided into two groups, the Yaksan and thoracic squeeze technique, which were administered to the experimental group, that is 10. And every participant finished the post-intervention evaluation and the 4-week intervention. There were no participants lost to follow-up. Baseline evaluations are finished, follow-up period assessment were finished 4 weeks after the intervention. The pilot study was finished on schedule and did not end early. So this is the discussion, which is actually the important part. This recent evidence, which is being done and reviewed after thorough reviewing of the recent advances article, which suggests that the chest physiotherapy techniques such as the thoracic squeeze are safe and effective in improving oxygen saturation, respiratory stability, and thoracoabdominal synchrony in the preterm infants. The action technique, though less studied comparatively, emphasizes gentle touch and parent-infant interaction, contributing to improved comfort and neurobehavioral organization. Both interventions are non-invasive, well tolerated, and show promise in supporting respiratory and behavioral stability in preterm neonates, highlighting the need for further large-scale studies to establish long-term outcome. So here I'm coming to the conclusion that is early non-invasive. We all know that a thoracic squeeze technique, as I have described, and action touch uh, are completely non-invasive and hold promising potential to enhance respiratory stability, reduce neonatal stress, and improve overall functional outcomes, making them valuable supportive tools in evidence-based neonatal practice. These findings actually helps in showed physiological stability and also the outcome measures like Anderson Behavioral Scale, Ballard scores, which also helped in showing better compliance in respiratory mechanics and neurodevelopmental stability in preterm infants. And then obviously there are also certain limitations like this. It is a feasibility study where only 20 preterm units were finally included with 10 participate in each group. Because limited number of subjects, the study may not have sufficient statistical power to strongly generalize the findings to all preterm units with respiratory distress. Therefore, these results should be viewed as a preliminary trends in definitive evidences. Then the outcomes were measured at baseline and at the end of the 4 weeks, which helps us understand short feasibility and immediately improvements. However, we were unable to evaluate the long-term effect of those techniques on important neonatal outcomes such as term respiratory morbidity, recurrent NICU admissions, progression towards bronchopulmonary dysplasia, neurodevelopmental disorder. Single center design limits the external validity of the results because NICU setting may differ in term protocol, stuffing, etc., strategies, nursing care, handling practices. Hence, the same outcome may vary when the study is conducted in different center. So, implications are the study has meaningful clinical and research implications for neonatal physiotherapy and NICU. The study shows that thoracic squeeze and Yaksan technique actually did not like functionally become very much like good in compliance, but also it can be safely administered to the preterm infants after following assessment. And it also showed promising trends in improving physiological stability and functional outcomes in preterm neonates. The strongest implication is that these techniques provide a non-invasive, low-cost, and early applicable supportive option that can be included in the routine NICU management without adding any medication burden. And also it helps in showing improvements in oxygen saturation, behavioral stability, etc., which is very much clinically important to analyze the like progression of the condition which is being suffered by or suffering by the neonates. So this is the future scope. In the future, this study can be expanded with the larger sample size and multi-center trials to confirm the effectiveness of the thoracic squeeze and Yaksan techniques in preterm neonates. Long-term follow-ups can be done to observe the impact on respiratory stability, neurodevelopment, and overall growth. The further research should be done in order to develop the standardized NICU physiotherapy protocol, include the advanced monitoring parameters, and evaluate safety and cost effectiveness for routine clinical use. So this is the references which I took. These are the references has been taken advanced articles and recent articles. By this, I'm concluding my presentation. I'm looking forward for the valuable insights from the respected panelists and questions from the respected panelists. Thank you.
I kindly ask our session chair to ask questions.
Actually, I do have one question. Uh, well,
Yes,
I
sir,
just
please.
want I
Thank
just wonder why you compare respiratory physiotherapy techniques with a calming touch therapy. This is a different techniques. For example, it's look like you are comparing between apple and orange. So
Okay.
which is
Yeah.
totally different. So the outcome it will be different. So how are you going to compare, and are you going to make sure that these two techniques can be compared? Do you get it?
Yeah, yes,
Because
I completely get it. Yeah,
the thoracic and
yeah.
Jackson techniques are different. So I
Yes, sir.
I don't get it why it can be comparable.
Thank you, sir, for the question. It will help me to give valuable insights also. Sir, actually, the thing is that those preterm units, you all know that they are having various types of adjoining motility. Okay, so deformities also they are having. So obviously, when a neonate is having suffering from like a neonatal respiratory distress syndrome, that time they also suffer from pain. So as a Yakson touch technique, there is the references like in Yakson touch technique. Actually, by giving the proper therapeutic touch, it helps in improving the pain condition uh, which is being assessed at the early, and then after following the treatment of giving Yakson touch, the pain condition has been improved. And also the thoracic squeeze technique along with, because as accumulation of secretions reduces the expansion of the lungs, as well as also like reduces as well as due to like weak intercostal muscles and diaphragm muscles, it also like increases secretion. So thoracic squeeze technique, what happens, like when you put a pressure like laterally to one thumb, and then another thumb is being put in the middle towards the end of the sternum, then it helps to improve the secretion. So sir, like pain as well as like accumulation of secretions are very highly correlated with each other. So that's why, sir, these two techniques are being given in order to improve the neurobehavioral compliance as well as to improve the respiratory compliance of the preterm units.
Okay, thank you.
Thank you, sir. Thank you. Thank you for having me.
I would now like to invite Komal Wagdare for presenting her paper Multi-Sync Efficient and Scalable File Synchronization in Distributed Systems, authored by Komal Wagdare, Shreya Bhokare, Varun Krishnan TK.
Hello, ma'am. I hope I am audible.
Yes, ma'am, you are audible.
I think first person is still sharing the screen. That's why I'm not able to share the screen. Hmm.
Yes, 1 minute. Please try again. Now it should be possible.
Hello. Just a minute.
Yes.
Good morning, respected chairpersons, reviewers, and fellow researchers. I am Komal Wagdare from Center for Development of Advanced Computing, CDAC, uh, Mumbai, India. Today, I am presenting our work titled Multisync, Efficient and Scalable File Synchronization in Distributed Systems. This work focuses on improving large-scale data synchronization across distributed environments. In this presentation, I will explain the motivation behind multisync, its architecture, operating modes, performance improvements, and future enhancements. So first of all, why efficient data synchronization matters. So in a modern distributed system, massive data is generated across multiple nodes. Maintaining consistency at scale is challenging, and slow synchronization can cause inconsistency, downtime, and delay in analytics. So therefore, efficient data synchronization is essential to ensure high availability, minimal downtime, and strong disaster recovery support. So this is especially critical in large-scale data centers and enterprises distributed environments. So before designing multisync, we surveyed existing file synchronization tools. So we found that rsync is highly reliable and bandwidth efficient, but mainly it supports sequential one-to-one synchronization only. So other tool improves performance for a large data set, while Parasync FE and FP-Sync and BBCP also support parallel transfer. We choose MSRSync as our base tool because it combines the parallel execution with rsync compatibility. It is a lightweight, Python-based, modular, and it is easy to adopt tool. So this makes it an ideal foundation for building a tool that is both efficient and easily extensible. Now I will briefly explain the architecture of MSRSync, which we use as the base system. The working process consists of three main steps. First, the tool scans the source directory and prepares a complete file list. Second, this file list is divided into multiple chunks or buckets. Third, multiple parallel rsync processes are launched where each process transfers one chunk of files. Because of this parallel execution, MSRSync performs faster than traditional rsync for larger datasets. However, an important limitation is that MSRSync mainly support for local file synchronization. It is designed primarily for local transfers only. So this limitation was a key motivation for us to enhance the architecture and extend it toward distributed environments. So building on introducing the multisync. So building on MSRSync parallel architecture, we developed multisync to address its local only limitation. It transforms parallel synchronization into distributed and scalable and mode aware frameworks. Multisync is designed to handle data replication across multiple remote nodes efficiently while it retaining MSRSync's core advantage of parallel processing. In short, it provides a robust foundation for managing large-scale distributed data transfers in real-world environments. Now I will briefly highlight the key features of multisync. First, it supports three structured synchronization modes: one-to-one, many-to-one, and many-to-many. These are the three modes. Second, it supports remote synchronization, which overcoming the local only limitation of MSRSync. Third, it implements parallel bucket-based file partitioning, where large datasets are divided and transferred concurrently to improve the performance. Fourth, it introduces shared metadata coordination, which manages synchronization information across multiple nodes. Finally, the multisync ensures efficient resource utilization by distributing the workloads across the multiple parallel processes. So all these features collectively make the multisync as a scalable and structured solution for distributed data replication. Now I will explain the overall architecture flow of multisync. So during the setup phase, all the source and destination details such as IP addresses, usernames, and a directory path are defined in configuration files. So the system is already pre-configured before the execution. At runtime, the user simply select the required synchronization modes, like one-to-one, many-to-one, or many-to-many as per their requirement. Once execution begins, multisync reads the configuration file and identifies the corresponding source and destination nodes. Next, it does the directory scanning and metadata collection and generates the file list by dividing it into the multiple buckets for workload distribution. Shared metadata coordination ensures the proper synchronization control. After that, multiple parallel rsync processes are launched where each process handles a specific bucket of files. This structured flow enables controlled, parallel, and distributed synchronization across configured systems. Now let's see the each mode one by one. In one-to-one mode, multisync manages synchronization between a single local source and a single remote destination. The dataset is divided into buckets and dispatched through multiple rsync threads over a remote connection. This mode is appropriate for direct data transfer across the endpoints. In many-to-one mode, multiple source systems synchronizes data to a shared destination. Each source node accesses shared bucket metadata to dynamically select and transfer non-overlapping files to a common destination. In many-to-many mode, multiple source and destination nodes participate in concurrent synchronization. Source and destination are independently paired, and shared metadata coordination ensures the balanced workload distribution without duplication. This mode enables the parallel data transfer across the entire system and significantly improving the scalability and overall throughput. So to evaluate this multi-sync, we conducted experiments in a controlled Hyper-V virtualized environment. We used Ubuntu 24 for virtual machines connected over a 1 Gbps Ethernet network. The system was implemented in Python using rsync for data transfer along with the Fabric and Invoke libraries to manage the remote execution. We tested large and mixed types of data sets with the recursive directory structures to simulate the realistic distributed scenarios. Now coming to the results, the x-axis represents data set size in GB and y-axis represents the synchronization time in seconds. We compare rsync one-to-one multisync and many-to-many multisync. As the data size increases, time increases for all the methods, but multisync consistently performs better. The many-to-many mode shows the lowest synchronization time, which demonstrate better scalability through distributed parallel transfer. Overall, the result validate the efficiency and scalability of our proposed architecture. So to analyze the scalability, we defined a theoretical model where T of n represents the synchronization time for n parallel nodes. D is the data size, B is bandwidth, and N represents the efficiency. So in the graph, the x-axis shows the number of DTNs and y-axis shows expected synchronization time in seconds. As the number of node increases, synchronization time decreases significantly. However, after a certain point, the improvement gradually levels off due to a resource limitation. So these trends align with the both our theoretical model and experimental results. Finally, to conclude, multisync provide mode-aware and scalable synchronization, which means it can adapt to different deployment scenarios easily. It supports multiple deployment modes, giving flexibility depending on the system requirements. It shows a strong scalability in many mode, efficiently handle the large distributed data transfers. The tool ensure efficient resource utilization and follows a storage independent architecture. So it's not tied to any specific file system. Overall, multisync offers a robust solution for distributed data replication, making it reliable and practical for real world deployments. Moving on the limitations. First, the performance is constrained by file specific factors rather than the overall architecture. Second, the current implementation is platform specific, mainly Linux dependent. And finally, does not yet chunk level parallelism for very large files, so which could be further improve performance. So finally, looking ahead at future work, we plan to focus on performance tuning with file systems like PNFS and Lustre to further improve efficiency. we also aim to implement chunk level parallelism for very large files and add enhanced feature like failure recovery with automatic retries. Additionally, we want to extend multisync to platforms beyond Linux, making it more widely deployable. So this will make the tool even more robust and versatile for distributed data replications. So that concludes my presentation. Thank you for your attention.
I kindly ask our session chair to ask questions.
Actually, that would be great if you can get back to your slide number 3.
Okay.
Actually, I do have a lot of question in your presentation here because well, on slide number 3 you said that rsync is not parallelism. Actually, rsync is parallelism. Yes, here you said it is not parallelism. Actually, it is parallelism, but it depends on your implementation. Because the rsync is a single thread and a single process, but there is a new version of rsync that is a single process and multi-thread. Okay, and it is not just that. The rsync is the most reliable for the distributed file synchronizations, and it has been used for a large scale backup systems. And it used for Linux distribution also, and it used for data center as well. Okay, so if you claim that, it would be a conflict to many research. So I just wonder that well for your research the your assumption is not correct. And
Uh,
the next one, okay, the next one you said that your research is more scalability. So when you talk about scalability, what does it mean? You haven't specified that. What do you mean actually? Because you test it on the virtual machine, right? The virtual machine and practical machine is totally different. And well, it depends on the node, the data size, and the concurrencies. But you haven't mentioned about the concurrency of thread and the process as well. Okay, so we don't know that what is your baseline for the concurrency, because when you talk about the synchronization, you have to talk about the concurrency first, but you haven't mentioned it. How many threads that you are using? For example, if you compare the async for just a 10 process, so it would be a 10 thread, right? And for about the MSR sync, it might be 100 thread. So it cannot comparable.
Yes, sir. Thank you for the question. As you told that rsync does the parallelism, but as I explored the rsync, so they told that rsync is a single threaded. So it
No,
does
it is
not.
not. It is a single thread,
Yes,
single process, but you can implement it as a 10 process with a 10 thread for a
yes,
file.
yes.
There's
That
no restriction that you have to implement it as a one process and one thread.
yes.
Otherwise, many people won't use rsync because rsync is a well-known technique that we have used for years.
Yes, sir, but that only rsync we cannot use for parallelism. That's why I am saying the tool which we explored, MS rsync, is also using rsync behind. But if we can say if rsync does the parallelism, if there are two directories like source and destination and if you are running rsync, then it is a single threaded. That's what I am saying. If you use rsync directly, it is a single threaded. But yes, you can do some external things to make it as a parallel, like ms rsync tool does in python. It is by using multiprocessing and all, it is invoking the multiple threads of rsync to send the data parallelly. So I think these two things are very different.
Yes, so you have to mention that based on your research, you compare it just one process and one thread.
Okay, okay. I
Do you
have.
get what I mean? Because otherwise, uh, it will be not fair
Yes,
comparable.
yes,
Okay?
yes.
Because
Hmm.
you said that rsync you just use one process. Yes, rsync is just one process and one thread. But the ms is, well, you can specify as many as you want. Well, that is not fair because the rsync can implement as many as you want as well. Okay? So
Oh,
that is why, well, it is not fair in your comparison.
okay.
Okay.
So there are any another questions for me?
Concluding the presentation, we have our next paper presented by Asta Golivere on nomophobia and its association with anxiety and depression and perceptions of AI-driven chatbot support among undergraduate physiotherapy students, authored by Asta Golivere and Sharat Hulumani. As Asta is not available,
So, hello,
Sharat Hulumani.
am I audible?
Yes, you're
Okay.
okay.
Good morning, everyone. Imagine forgetting your phone at home and feeling anxious, restless, and disconnected. This experience reflects as growing phenomenon known as nomophobia. Today, I will present my study exploring its association with anxiety, depression, and potential role of AI-driven chatbot support among the undergraduate physiotherapy students.
Excuse me, you just lost your presentation.
Uh,
It is visible now.
okay. Just a second.
Yeah.
Okay. So, the rapid rise in smartphone use has transformed daily life, but exaggerated dependence has led to nomophobia, the fear of being without mobile phone connectivity. Nomophobia is increasingly prevalent among young adults, particularly university students, and is associated with heightened psychological distress. Emerging evidence indicates a strong association between excessive smartphone use, anxiety, depression, sleep disturbance, and reduced academic performance. Undergraduate students may especially vulnerable due to academic stress, social pressure, and constant digital engagement. Artificial intelligence, that is AI-driven chatbots, intervention have recently shown promising in supporting mental health by reducing symptoms of anxiety and depression. The study explored the association between nomophobia, anxiety, and depression and examines perception of AI-driven chatbots support among undergraduate physiotherapy students. Now, if we see the rationale, there was a excessive smartphone use uh, is increasing nomophobia, which is linked to anxiety and depression in physiotherapy students. Academic stress, constant digital dependence make this group more vulnerable. Like physiotherapy students, they face academic pressure, clinical responsibilities, and constant connectivity, making them especially vulnerable to psychological distress. AI-driven chatbots, they offer confidential 24/7 low-cost mental health assistance, promoting coping strategies and emotional regulation. Research significance, if I will see, so there was an understanding the relationship between nomophobia, mental health, and AI support that can guide a future digital intervention to improve student well-being and reduce unhealthy phone dependence. Okay, so the aim of my study, it is to find the nomophobia and its association with anxiety and depression and perception of AI-driven chatbot support among undergraduate physiotherapy students. The objectives are to determine the prevalence and severity of nomophobia among undergraduate physiotherapy students, to assess its level of anxiety and depression in study population, to examine the association between nomophobia and anxiety among undergraduate physiotherapy students, and to examine the association between nomophobia and depression among undergraduate physiotherapy students, and to explore perceptions and acceptance of AI-driven chatbot support for mental health management. So methodology, my methodology, if we see the study design, it was an observational study. So it was conducted over 1 year. Study setting was undergraduate group was 18 to 25 year. It was okay, sorry for the disturbance. So the assessment tools I used was NMPQ questionnaire, that is nomophobia questionnaire, then depression, anxiety, and stress scale, TM-based perception scale. Study procedure. So for this study procedure, first I had taken the ethical approval, which was an informed consent secured from all participants, like students of age group 18 to 15 years. We have screened using the inclusion and exclusion criteria. Eligibility participant provided demographic details and smartphone users information. Standardized tool administered was NMPQ to assess the nomophobia, DAS-21 to assess the anxiety and depression, and TM-based scale to assess perceived useful and of AI chatbot support. The result we will see is nomophobia and depression. There was moderate level of nomophobia was observed among students. Depression score were notably present in the student population. Nomophobia showed a strong statistically significant positive association with the depression, that is P less than 0.001. Higher nomophobia levels were linked to increased depressive symptoms. Now, nomophobia along with anxiety association. So the anxiety level were evident among the undergraduate physiotherapy students. Nomophobia demonstrated a moderate, statistically significant positive association with the anxiety, that is P is equal to 0.002, and increased nomophobia corresponded with higher anxiety levels. So in discussion, the study demonstrated a moderate, it demonstrated a moderate to higher prevalence of nomophobia among undergraduate physiotherapy students, a population exposed to academic stress and continuous digital engagement. A significant association was observed between nomophobia, anxiety, and depression, supporting evidence that problematic smartphone use negatively impact psychological well-being. Factors such as female gender, early academic year, high daily smartphone use, and frequent phone checking were linked to higher nomophobia levels. Excessive smartphone dependence was also associated with sleep disturbance, reduced concentration, and academic performance concerns, further intensifying mental distress. This finding highlights the need of institutional strategies promoting digital well-being and early mental health intervention. In this context, AI-driven chatbot support emerges as a promising, accessible tool for monitoring and managing anxiety and depression among students. So the conclusion, we see that is nomophobia showed a significant positive association with anxiety and depression among undergraduate physiotherapy students, indicating the higher smartphone dependence linked to a greater psychological distress. The finding highlights the urgent need of early psychological screening, structured interventions, and digital health education within academic institutions. Female student and younger undergraduate appears particularly vulnerable, emphasizing the importance of targeted preventative strategies. Positive perceptions towards AI-driven chatbot support suggest a potential and an accessible tool for promoting mental well-being among the future healthcare professionals. Thank you.
I kindly ask our session chair to ask questions.
Okay, actually, I do have a lot of question in here because you have mentioned about the technology acceptance model, right?
Yes.
Because you haven't report any necessary value to indicate the technology acceptance model. For example, you haven't show the conceptual model and about the construct model and about how you validate the reliability and the correlation, and many value are missing in here. Yeah, so I haven't seen any, for example, about the discriminant reliability in here. What is the AVE, the convert alpha, and the factor loading of each questions, and how it form up to be the conclusions, and which link is the critical path. So there are a lot of things missing in here. You just came up for the results. So where's the rest?
Can you repeat the question, sir?
Yeah, because actually you have to present your model. Okay, so how you came up with your model and what is the importance of your model to conclude for the result. But I haven't seen any. Okay, that would be
Models are
my
very
comments. But if you don't have it, it's okay. But that would be my comments. Actually, you have to present all of those values.
Thank you, sir.
Now I would like to ask Sharat Hulumani to present his paper on development and validation of evaluation form and inclusive development support module empowering mothers and healthcare providers in preterm infants, authored by Sharat Hulumani and Irshad Qureshi.
So can I start? Can I share my screen?
Yes, sir.
Yes. Is it visible? Is the PPT is visible?
No, it's not.
Okay, just a minute.
It's not actually.
Just a minute. Now it's visible.
Yes, now it's visible.
Okay, can I present this paper or previous paper?
The development one.
Okay,
Paper.
sorry. Yes.
Yes.
Yes. So it's visible, right?
Yes, actually your screen is also coming. Your camera.
Okay, sir. Yes. Good evening, everyone. Good evening, sir. So today my presentation topic is of development and validation of evaluation form and inclusive development support module. The short form what I kept is for IDS MEMH for preterm infants. So myself, Dr. Sharath Ulamani, I am an associate professor and ed in the Department of Pediatrics and Neonatal Physiotherapy, Ravinar Physiotherapy College, Datta Mega Institute of Higher Education Research, Varda. Coming to the like background, what exactly this particular thing is like developmental modulation. Why I took preterm infant? The preterm infants are mainly are the higher risk of the developmental delay. This was the first problem, and the second one will be for this particular developmental delay. So we should be having a structured developmental surveillance, and also we should be having a early intervention as well as early identification. And the second what important gap what I got was there is a huge gap between the hospital-based care and the home-based follow-up. As the baby is in neonate, once the baby's got discharged, we can't able to meet the baby. That's the biggest gap where we're giving treatment in the hospital-based as well as in the home-based. This is the second gap. And the third one will this for this particular thing we should be having the one the baby got discharged. We should be having a intervention for that particular baby. For that particular intervention, we should make a module. That is what this module is developed. That is IDS-MEMA, that is evaluation, inclusive development and support module, mainly for the preterm infants once the baby was discharged from the hospital staff. So what are the problem statement? The first main problem statement is the lack of validated caregiver centered developmental module. We have a lot of modules in entire India, but we don't have exactly validated caregiver documents. So how to proceed further? This is the first one. The second one will be there will be very limited structure evaluation tools for preterm infants. As we want to diagnose early identification, we are having very limited evaluation tools. For this particular thing, we should be having a exact modulation or exactly model to structure. And the third one will be we should be having a need evidence based and inclusive support framework. We can make lot of framework or lot of guidelines, but without evidence based, it's very difficult. This was the three main important problem statement. Coming to what are the objectives? The main two objectives for this particular study is first we are designing that includes development support module. After designing that particular design, we are going for modulation or validation. That is what is the second objective of this particular study. And a study design, as already told, this particular study is a multi-phase developmental study. In this, we are having two main phases. The first phase is of model development, and the second phase is of module validation. And this validation is mainly done by the expert-based content approach. By the expert only, this particular model will be validated. That procedure I will tell further. Coming to phase one module development. So in this particular module, what exactly I did is we did a thorough literature review. We did after mainly for the preterm developmental. After literature, we did a FDG, that is a focus group discussion, mainly with the neonatologist and the physiotherapist. Here we included the neonatal nurses, and we also included the one more important part is we also included the mother as well. This is second we did as focus group discussion, and the second part, third part we did the clinical observation on the preterm infants. After that, we find out the identification mainly for the developmental milestone and also the what are the caregiver strategies that can be given. These are the main four steps that is involved in the phase one. And coming to phase two, what we exactly did is the validation process. Here we did a panel member that is mainly of 10 members. So in the 10 members, we included neonatologists, nurses, physiotherapists, also the mothers we did. How we exactly took the data source? We mainly took the expert opinions, mainly in the three part. The first part is the clinical observation, and the second one is the existing neonatal care guidelines, and the third one is the important, that is the caregiver feedback, because the caregiver is the one who wants to treat the baby once the baby got discharged. These are the main three data sources we took for the phase one. And what are the main components of these particular modules? So here we are having only one important component, that is positioning and handling techniques. In this, again, we divide into three main parts. The first one is the motor developmental strategies. And the second one is the sensory stimulation, where it included visual, auditory, as well as the vestibular. And the third one is the caregiver training and the education material. These are the main three components that comes under the positioning and handling techniques. And this particular evaluation form is mainly structured into 15 questions. In these 15 questions, this particular 15 question has to rate by the 10 experts with having the 4-point relevance scales. By this relevance scale, we'll calculate the CVI, that is the content validity index, by this particular score given by the 10 experts, that divided by into 4-point relevance. Coming to phase 2, as already mentioned, in this also same exactly we are doing. Here also we are calculating the CVI, that is with CVI we also calculate ICVI, that is a proportion of the export rating time as a relevant. So ICVI, SCVI, that will be calculated according to that. And acceptable ICVI is it should be more than 0.78 or equal to 0.78. Then only we'll consider this particular model is a good bad model. It is appropriate or not appropriate. Once it reaches more than 0.78. Coming to the results, so we made a model and we gave to the 10 experts, neonatologist, physiotherapist, nurses, and the caregiver. After that, what exactly we got the result. So from this, what exactly we got is expert agreement. A majority of the items achieved ICVA, that is 1.0. So this concludes that this particular model is having a strong universal agreement for most of the items, and some items require revision based on the expert suggestions. So if you want to see that particular results, so we can see here. So what exactly happened is from 1 to 15 questions, most of them give one ICVI, and the universal agreement for the question number 2 and the question number 10 and the question number, I think these are 2 questions. There's a question number 2 and the question number 10. After this validation, again, that particular 2 questions are refurnished, and that particular refurnished document is not published. This is only before the refurnished document what we are giving the results. These are the particular CVA index, where we can see that is second question and 10th question is having the 0. They will having certain kind of conflict by the all kind of neurologists. Most of the experts, that is give a conflict on the question 2 and the question number 10. So we can see here the overall module exactly questions what exactly we asked and what are the expert we got. Can we see here in the question number 2, all the expert gave 0, and the question number 10 also only for one expert, that the 10th expert they gave the 0. Rest all is concluded by this. So right now we, from according to this particular thing we calculated from the total 10 expert, that is equivalent to 15 questions. And the ICVI was 1.01 average, and by SCVI was around 0.86, and CSV was the 0.86. SCVI I already told, that is the universal agreement, and SCVI is the average base scale content validity. So this is the whole module Excel sheet that I converted into image, and downwards we can see the exact graph, what exactly the exact varying. You can see the valid question number 2 and the question number C, it is somewhat varying. So these particular part is the results part. Coming to what the statistical outcomes, what exactly we got. So the average score for CVA, what we got around 0.86, and this particular demonstrate the strong content validity, and also the high expert consensus across all the domains except the second and third domain. These are the two second and 10 domain. These are 2 domain where the conflict as came from the experts. So what are the key findings by particular this model? What I can suggest is the first model is mainly clinical relevant and practical. What I can suggest from this is, and also it can improve the caregiver clarity and the confidence, and it also bridges gap between the hospital as well as the home care. And the third most important is that it mainly supports the early developmental outcome. These are the main key findings. If we implement this particular model, what we can give the suggestion. And the most important strength of this particular module is the expert driven development process is the main first particular thing. And the second one, it is a multi-phase structured validation. And the third most important is it is EBP, that is evidence based, practicable, and the research backed framework. And the last one, it is focused mainly on the inclusive caregiver empowerment, where the infants with preterm infants or the NICU graduates is mainly lacking with this particular thing. These are the main strengths, and the limitations also we have. So mainly we have 2 main limitations. The first limitation is it mainly requires the field-based validation. This validation we did on the hospital setup. After this, once Pura, it is like second and 10th question is content, it's validated, then we'll proceed with the field-based validation exactly on the neonates. And the limited expert peer review phase, we have only limited expert panel, only we took the 10 members. So further we can take more than 10, maybe we can add 10 neonatologists, 10 nurses, 10 physiotherapists, 10 caregivers, maybe we can increase the expert panel. For this particular thing, we we decrease the less expert panel as the first phase of the study. Coming to what the clinical limitation, the clinical limitation will be it mainly supports a structured home-based intervention, and the second one will be it mainly enhances the multidisciplinary neonatal follow-up care where the neonate is mainly lacking. So the follow-up can be if lacking also, we by this model we can at least guarantee that okay, the mother is doing according to our particular model. At least we can day to day basis we can have the nice good follow-up. And the future direction, what we are thinking is large scale clinical implementation has to be done, and the longitudinal outcome assessment has to be done, and also we can use for the policy level neonatal care adoption according to the Indian neonatal scenario in the as we are a low income country, so according to we can proceed with this particular module. And according by this, what I exactly conclude is it mainly demonstrates the strong content validity, and it achieved almost ICVI and US scores, universal scores. And it also, I can suggest that it is effective tool for empowering mothers as well as the healthcare providers. And it is one of the promising approach mainly for improving the preterm, mainly to decrease or to delay the developmental outcomes where the baby should, where the baby should not get further complication. What I told, I risk in neonates. So these are the references I took from the reference from the WHO, the 2018 preterm birth. And these are the three main references where I took the Smith et al. Early intervention programs and the collaborative neonatal care from the Johnson Kumar 2020. And the content validation index I took from the Polith and Back. From the content validation index only, this entire module is taken and calculated according to this particular article, that is Polith and the Beck. Yes. Thank you.
I kindly request our session chair to ask questions.
Okay, I do have some question. Well, it seems to contradict for the results because you said that the ICVI is 1, and then SCVI is 0.86, right? So that seems the ICVI is except for all questions for 15 questions, but the SCVI is seems to accept at most 12 or 13 questions. And well, normally if the ICVI is high, then SCVI should be greater than 0.9 normally.
Yes.
Okay, but in this case, it's below it lower than 0.9. And one more thing, actually, you should present the modified kappa statistic also, because the modified kappa statistic will show, well, even if it contradict, but if the modified kappa is acceptable, that would be support your result.
Modified capacity.
Okay. Yeah. Okay.
So actually, what exactly happened? These two questions is having some conflict. So further step, I'm doing a modified COPA scale, and it's almost done. So I'm just this is the previously one presented.
Okay.
Yes.
Thank you.
Yes. So can I present one more one, madam?
Yes, sir. Moving on, I kindly request Sharath Hulumani to present his next paper on maternal health factors influencing neonatal respiratory distress syndrome in Indian newborns, a cross-sectional analysis.
Again, good evening, everyone. So this is my second paper. The paper ID is 617. The presentation topic or the research topic is of maternal health factors that influencing the neonatal respiratory distress syndrome in Indian newborns, a cross-sectional analysis. As myself, Dr. Sharath, I'm currently working as associate professor and head of the department in Department of Pediatrics and Neonatal Physiotherapy from Ravina Physiotherapy College, Datta Mega Institute of Higher Education Research, Worth. Coming to introduction, what is the main need for this particular study? Before that, I can tell what is NRDS. NRDS is mainly considered as, NRDS is mainly disease of hyaline membrane disease. It is mainly predominantly that is mainly seen in the preterm neonates born before the 28 weeks of the 28 weeks of the gestation. And it is also severe respiratory condition that mostly affects the preterm infants. So according to WHO and recent papers, it is the inverse relationship between the gestational age, and it is more prevalent in premature babies, particularly those born before the 28 weeks of gestation. These always link with the emphasis of the surfactant and a lipid protein combination made by the lungs type 2 alveolar cells, and mainly the premature babies frequently experience this particular elevated surface tension due to a lack of surfactants and also with the oxygen exchange. This is the main particular reason for the diagnosis of NRDS. The main cause, what I can tell is the main first cause will be of increased alveolar surface tension leads to alveolar collapse that reduces the lung collapse, and the end of the thing it is the respiratory failure will be progressively decreased. This is the main cause, and it mainly and it rarely affects the term neonates, and it requires a early identification if the term neonates is diagnosed, and it also it is always increases the neonatal mortality and the morbidity. Coming to what are the complications or what NRDS exactly leads to. The first thing that is leads to NRDS leads to neonatal mortality. From that neonatal mortality, the first important thing is the preterm infants that will be severely affected. The main reason can be the maternal risk factors, and this particular thing is still underexplored, and it is one of the important gap. And further research has to conduct what are the maternal risk factors. That is what this particular study what I did is. And the second one will be Indian data on NRDS is very limited. And the third part is the very early identification. If we identified early, the rate of complication is very limited. By this, we can prevent the dependence mainly on the maternal health. And if we diagnose early, and even early intervention also can be proceed as soon as possible. Coming to my research question. So, which maternal health, as I already told in the previous slide, maternal risk factors remain underexplored. That is what which maternal health and obstetric risk factors are independently associated with the development of NRDS among neonates delivered at tertiary care center in Varda. This is the main research question. Varda is a local place where I am right now currently I am staying. So this is the place where we are having a lot of NRDS babies we are getting. That's what I want to see exactly. What is the main reason, whether maternal health or obstetric risk factors, and what is the exact reason? There is a main study, that is the main research question for this conducting for this particular study. Coming to aims and objective, we are having main three aims, that is to ascertain the effect of maternal risk factors, to identify and examine the important maternal factors, and the third one is the management and preventive strategies. These are the main three aims as well as the objectives. Coming to methodology, this the particular study design is a retrospective observation analytical study, and the study setting, as I already told, we did in Varda. That is a hospital name is AVBRS, that is Acharya Vinoba Rural Hospital, Savangi Mege. Before doing this particular study, we went with the ethical institutional ethical clearance, and we also obtained the ethical clearance and with the reference number mentioned here. And the study population is the preterm neonates born less than 28 weeks of gestation, and we took the data source from the our particular hospital MRD, this medical record department, from 2024 to December 2024. And the study group is mainly of two groups. Mainly first group is NRDS, and the second group is the non-NRDS neonates. And we collected data into two main things, that is the maternal variables, and the second one is the neonatal variables. And we took a very basic statistic, that is categorical and continuous variables, where we use the categorical data, that is mainly frequency and percentage, and the continuous data by the mean mean standard deviation. And we use the t-test and Mann-Whitney test for continuous variables. We thought to do multivariate analysis, but we haven't concluded that still. And the outcome measure what we use is crude and adjusted one with 95% confidence interval. Now coming to variables, we use the maternal variable as anthropometric and health information, mainly the information gathered from the mother's medical record. And the second one is the neonatal variables, where we took the 7 part. The first part is gestational age, and the second one is respiratory distress diagnosis. The third one is the requirement for neonatal resuscitation at birth. And the fourth one is meconium, presence of meconium aspiration and meconium amniotic fluid, APGAR score, and our ABG score, and occurrence of hypotension in the first 24 hours of life. That's the main neonatal variables. Coming to outcome measures, we took 7 outcome measures. The first one is occurrence of NRDS. Second one is the maternal risk factor association. Third one is the gestational age, APGAR score at the 5 minutes, and then the neonatal resection, it is need is there or not, and what is the NSU length of the stay, and the last one is the neonatal clinical outcome. So this is what is the result. What we got is, so we got around 250 neonates. In that 100 neonates are NRDS cases, and 115 are non-NRDS neonate. That is within control group. So what I got exactly found is mean gestational age was 23.6 week in NRDS group, and a non-NRDS group is 36.4 weeks. Coming to mother's age was around 37.8 years, and the non-NRDS it was around 31.2 years. By this, I can tell that NRDS neonates significantly is having more preterm, and they're having a low birth weight in NRDS group, and maybe maternal diabetes and hypertension can be the one of the significant thing, and also the secondary will be consanguinity, and the maternal age can also be the independent predictor for this particular maternal disorder. If I want to see the exact result according to categorical data, so in NRDS group, mother who are having 39% is having gestational diabetes, and the two mother is having a trauma, and the 16% is having hypertension, and the 20% is having consanguinity marriage, and the quickening was not present at the 19% mother, and 5% was the late during pregnancy. By this particular status, we can see that three main things we can tell the incidence. The first incidence will be the gestational diabetes, that is 39%, and the second most will be the quickening was absent, and even the consanguinity marriage was the second thing, and the third one will be the hypertension. These all can see in NRDS. Coming to non-NRDS also, we can see almost 109 baby was not having quickening, and the second one is the second important is gestational diabetes. Even in the non-NRDS also, it coming to conclude that gestational diabetes having the higher role or the first priority or the first important maternal risk factors that makes the baby to get diagnosed to neonatal respiratory distress syndrome. Coming to maternal age, what we exactly saw is in NRDS, the baby age was around 26.3 weeks average. The birth weight you can see is 950 gram, and the 98 babies was not cried immediately after the birth, and the mother age was around 33.2 was the median, and the 37.8 was the father median. Apgar at 5 minutes for the 4 baby, and you can see 98 babies were cesarean section out of 100. Only 2 babies were delivered in the normal vaginal delivery, and in the 37 babies were having meconium aspiration. By this also, again, it is come to conclude that maternal complication or maternal characteristics is the main important cause for the neonatal respiratory distress syndrome, where the baby has to suffer in further lifetime. This is what I mentioned, odd ratio cyclic multivariate analysis. It's like coming to discussion, what exactly the thing. As I told, the first thing is the premature remains the strongest and very important NRDS determinant. Gestational age, immature alveoli, increased surface tension, maternal diabetes, hypertension, consanguinity marriage, and even low upgar. These all are the one of the important characteristics where the baby can get or baby is diagnosed with NRDS, where the upper hand is from the maternal side, where the mother is having the upper hand. It's not like we can't tell congenital and all. This particular thing is mainly almost 39 to 40% the baby, so neonatal diagnosis NRDS is the main factor is the maternal risk factor. And coming to conclusion, what I exactly concluded from this is maternal health is the main significantly, if the maternal health is good, so we can significantly decrease the health disorder. By this, what I exactly conclude is maternal health issues and obesity problems are important factors in development of NRDS. By this study, we confirm that early detection and treatment of high-risk pregnancy is important, and by this, the burden of NRDS can be considerably decreased, improving neonatal outcomes by implementing the focused prenatal therapies, by the increasing the mother health, and also by the improving the neonatal respiratory care. By this, we can early identify. If we early identify, immediately the next most important thing is early intervention. So these are some of the important references which I include in the whole manuscript. But for the catchy, I mentioned all the references from particular manuscript. Thank you.
I request the session chair to ask questions.
Okay. I think if it is possible, or can you show the first slide of your results? I think there are some typo, and because you said 31 year, I think.
This one?
Yeah. You said 37.8 years. I think
Yes.
it is not correct. Yeah, it should be week. Okay. And the next slides. Okay. And in next slides, you report the frequency and everything, but actually you're missing some important the standard deviation also because
Okay, yes, yes, yes.
yeah, because otherwise we don't know that what is the
Yes,
different range of data that you get.
yes, yes,
Okay,
yes.
and uh, otherwise I think that would be okay. That would be good. Thank you very
Yes.
much.
Thanks so much. Yeah. Thank you.
Yes. I sincerely thank our authors for their excellent presentations and contribution in this session, and all our participants for being a part of this international conference. I hope this session was informative enough. We, on behalf of the whole team, thank you for the support during this 11th version and all the previous 10 versions of the conference. We will be happy to have you in the 12th version in 2027. All the presenters would be getting their digital certificates through email within 2 working days. The publication will be live within 7 to 8 months. Kindly cooperate with the team of ICICT 2026. I also thank our session chair, Dr. Paniti Nitinand and Dr. Nilesh Modi, for chairing the session. A token of appreciation to the chair on behalf of the team ICICT 2026 and Global Research Foundation and partners. Thank you for your valuable presence. I kindly request you all to switch on the camera for a quick snapshot of the virtual conference.